The worldwide prevalence of diabetes has risen significantly. According to 2021 IDF Atlas, the figure is 463 million, out of which one-fifth is from Southeast Asia. India, with 77 million, that is 7.7 crores, is a major contributor. Simply speaking, 1 in 11 adult Indians are diabetic, which is an underestimate, as many experts feel. So it is time to act fast and act decisively. Since the advent of metformin and sulfonylureas in 1960s, these two remained a mainstay in the management of hyperglycemia in type 2 diabetes. Of course, they still are. However, this new millennium has seen rapid strides in oral anti-diabetic drug development. With the advent of DPP-4 inhibitors, SGLT2 inhibitors, and of late, oral protein in pill GLP-1 receptor analogs, we have seen new and newer drugs coming for the better control of hyperglycemia in the vast majority of type 2 diabetic patients. Two major common features of these new drugs are: one, cardiovascular safety, and two, complete avoidance of hypoglycemia. In a way, we are living in an exciting time. In this backdrop, we discuss an interesting patient presenting with some clinical dilemma. Mr. RK, 46-year male, has been a diabetic for last 8 years. He is a civil engineer with a transnational road developing agency. His work schedule demands long stretches of driving out of town to supervise work at the construction sites away from the city. Since last 4 years, he has been on glimepiride 2 mg along with 2000 mg of metformin daily. His hypertension and dyslipidemia, which were detected a year back, has been managed with telmisartan and atorvastatin. Blood pressure control has not been very satisfactory. His current lab parameters: fasting blood sugar of 180 mg per deciliter, postprandial of 275 mg per deciliter, and glycated hemoglobin stands at 8.4%. He has microalbuminuria with an estimated glomerular filtration rate of 64 ml per minute, which puts him in the stage 2 of diabetic chronic kidney disease. When he approached his company physician with these lab reports, treatment intensification was done by increasing glimepiride dose to 4 mg daily. Since then, his quality of life has gone for a toss. He had 7 episodes of pre-lunch hypoglycemia, one of which was severe, requiring him to be taken by his colleagues to a primary health center nearest to this construction site, where he was injected with intravenous dextrose for recovery. For obvious reasons, his meal intake had been quite erratic at his construction site, all these years, and this is mainly due to his field visits away from the city. In this situation, Mr. RK was compelled to seek a long leave, jeopardizing his next promotion, making him very depressed. He was at a loss as to what to do next. At this point, his intelligent and concerned wife, who is a maths teacher in the local college, insisted on seeing an expert in the field. The expert, after reviewing his history and lab parameters, stressed on 3 major points. Number 1, need to achieve an optimal glycemic control to prevent long-term microvascular complications. Number 2, need to avoid hypoglycemia at all costs, looking at the professional hazards and the reduced quality of life. And number 3, need to protect the vital organs, especially the heart, eyes and the kidneys, avoiding long-term morbidity and mortality. Mr. RK's wife wanted to know about the available options and the scientific data supporting them. To this, the expert informed about the relatively newer molecules like empagliflozin along with linagliptin. The fact that HbA1c reducing efficacy of this combination is to the tune of 1.6 to 1.8% without any increase in hypoglycemia seemed quite interesting to the couple. And moreover, they were also informed about ability of empagliflozin to reduce the cardiovascular events as shown in the cardiovascular outcome trials up to the tune of 24% compared to placebo. Moreover, the renal benefit of empagliflozin and linagliptin were also highlighted based on the EMPA-RACE trial as well as the Carmelina and Carolina trials which were completed recently. At the end of the shared decision-making process, the couple agreed upon addition of empagliflozin and linagliptin to metformin. However, Mr. RK was apprehensive about having compelled to use too many tablets. Then he was told about the availability of a fixed dose combination of empagliflozin with linagliptin, which seemed quite attractive to him, and he readily accepted this option. A follow-up visit after 3 months showed HbA1c declining to 7.3% from the baseline of 8.4%. And the fasting and postprandial plasma glucose were near optimally controlled. Further follow-up after 6 months showed HbA1c reaching 6.8% with regression of microalbuminuria and improvement of eGFR to 71 ml per minute from a baseline of 64 ml per minute. Quite substantial improvement. Steady blood pressure control and 2.5 kg weight loss was like icing on the cake. But the most important fact to make Mr. RK immensely happy was the 0 hypoglycemic events, which in turn enabled him to discharge his duties most effectively, making his seniors happy. Needless to say, he was awarded with the promotion which he was eagerly waiting for and which he so rightly deserved. His wife now has much less to worry due to all these developments. This case demonstrates how the choice of right combination of safe and effective drug give pleiotropic benefits and significantly impact the patient's health, productivity and quality of life, not only in the short term, but in the long term also. A seemingly small change in the prescription, but a big change in the lives of patients and people surrounding him. That's what the newer drugs with the option of fixed dose combination do offer in the treatment of type 2 diabetes mellitus at this present time. Thank you very much.